ADAURA trial was really one of the highest profile presentations at ASCO 2020, as reflected by its status as one of the plenary abstracts. This was a very positive study, and it looked at the question of whether there is a role for osimertinib, the third generation EGFR tyrosine kinase inhibitor, as an adjuvant therapy for patients with EGFR mutation positive early stage non-small cell lung cancer that has been resected. Trial was designed as a randomized investigation in which patients had undergone surgery and could then receive adjuvant chemotherapy, was not mandated, and about 55% of the entire population received adjuvant chemotherapy, a little less than we'd ideally like to see, but then were randomized to either get 3 years of osimertinib or 3 years of placebo with the primary endpoint of disease-free survival. The trial was terminated early and unblinded. I should say it was unblinded, but still being followed after the Data Safety Monitoring Committee reviewed some early data on it and saw a huge difference in disease-free survival that was reflected by the hazard ratio of 0.17 for patients with stage 2 or stage 3A resected non-small cell lung cancer, the advantage, of course, being with osimertinib over the placebo. And when it was a broader population that included patients with stage 1B disease, the hazard ratio for disease-free survival was 0.21. If we just looked at the patients with stage 1B disease as a separate group, their hazard ratio for disease-free survival was 0.5, so certainly good, but not in the same ballpark as those with higher risk disease. So what does this mean? The trial was extremely positive for the endpoint that was designated as the primary endpoint. And I don't think there's much controversy about that, but there is some ongoing discussion about a couple of things. One, is disease-free survival enough that it should change our practice in a setting where we really can expect a major effect, at least on a surrogate endpoint like disease-free survival, with an effective targeted therapy for patients with the driver mutation in question. And then I would say that those of us who are still debating the utility of this would say, yes, we acknowledge that this is a huge difference, but it is exactly what one would expect. It's exactly what other studies in this space that are not as comprehensive have also reported, but other studies have suggested, if not clearly shown, that survival was not different. These are different studies, shorter timelines of treatment and less effective EGFR inhibitors, but as a general trend, we've seen that these EGFR inhibitors are remarkably effective when people need them. And if they relapse and can do just as well without everybody having to get years of a therapy, that could be just as good for people. We don't want to overtreat people either, and we need to acknowledge that particularly for patients with lower stage, lower risk disease, a lot of patients would be getting years of a therapy when they are already cured and can't get more cured. And even a generally well-tolerated therapy like osimertinib has its issues with lower grade diarrhea and rash perhaps, and a few patients with prolongation of QTC interval and potentially more significant side effects, which is not a major common issue, but in patients who may already be cured, we really want to be sure that we are only treating the people who are most likely to be helped. So there's that issue, and then there's the sheer cost. This is a therapy that is in the range of at least $15,000 to $20,000 per month in the US. So we're talking about over $200,000 every year. And that could be arguably money well spent if more patients are alive because of this intervention. But if we don't show that, and if in fact patients can relapse, go on osimertinib and do just as well with control of their disease for years on relapse, but never needing it until then, it might be a significant expense to pass on to society without as clear a benefit. So these are the debates that I think many of us are still having, whether DFS is enough or whether we really would want to see overall survival. I think most of the academic trialists would say that ideally, overall survival is the endpoint that we want and should want for early stage, potentially curable disease. And the other question is, how much or how little should we concern ourselves about the societal costs versus just focusing on one person in the room? So many big questions still to address, but clearly a very positive trial, at least for the endpoint that they were looking at.